My name is Gabor Kirs and I'm working in the Réunion Island, France. This talk was presented during the Congress of the European Society of Thoracic Surgeons in Budapest on May 26, 2025. Concerning the content of this video, I have no interest to declare. We will talk about anesthesia for awake thoracic surgery and non-intubated thoracic surgery. Non-intubated thoracic surgery can be awake or under sedation. And there's also tubeless thoracic surgery without an endotracheal tube, no chest drain, and no urinary catheter. What arguments are against non-intubated thoracic surgery? Well, it could cause mental stress in a moving patient with cough and paradoxical respiration, mediastinal shift, and could dangerously lead to hypercapnia and hypoxemia. And it's also contraindicated in the presence of contralateral phrenic nerve paralysis. In addition, hypercapnia should be avoided in patients with increased intracranial pressure, elevated pulmonary artery pressure, and heart failure. In spontaneously breathing patients with sedation, the laryngeal mask can lead to postoperative pharyngeal pain and gastric reflux, which contraindicates non-intubated thoracic surgery. In contrast to general anesthesia, in non-intubated thoracic surgery, cognitive function is preserved and there is no trauma to teeth and no trauma to airways. There is improved cardiac function, and there is a decreased right-to-left shunt. Protective cough and swallowing reflexes are preserved. And non-intubated thoracic surgery is used in fast-tracked surgery with faster recovery and reduced morbidity. Ventilation during general anesthesia can lead to volutrauma, barotrauma, and ventilation-induced lung injury, thereby increasing mortality. But studies for non-intubated thoracic surgery show less complication and lower mortality rates for awake video-assisted thoracic surgery, VATS, and even high-risk cases with a PPO FEV1 less than 30% can successfully undergo awake thoracic surgery. And non-intubated thoracic surgery remains an option in case of allergies to neuromuscular blocking agents, myasthenia gravis, and severe neuromuscular disease. There's reduction in operating room time, reduced pain with less postoperative complications, and consequently reduced or no ICU stay with shorter hospital stay, higher patient turnover, less need for nursing care, and finally, first and foremost, cost cutting. Good indications for non-intubated thoracic surgery are tracheal surgery, resulting in beta anastomosis, pathologies with chronic collapse of the operated lung, lung transplant patients and candidates for lung transplants, pneumectomy patients, pregnancy, limited duration of surgery, history of difficult ICU weaning from ventilation and patients with high risks for ventilator dependency, and also high-risk cases with reversible pathology. The small retrospective observational study showed that high-risk patients can successfully undergo awake thoracic surgery. Important to note in this study that preoperatively 8 out of 9 patients had the maximal score of 4 out of 4 on the Modified Medical Research Council dyspnea scale and presented following severe, mainly respiratory comorbidities, summarized on the slide. Advanced interstitial lung fibrosis on home oxygen treatment, history of difficult weaning from the ventilator, severe emphysema and COPD, restrictive chronic respiratory failure on continuous nasal non-invasive ventilation. There were 2 cases of advanced limb girdle myopathy, contraindicating muscle relaxants and volatile anesthetics. And also 2 patients with a FEV1 of 27%. Just a point. After publication of this paper, we could not include a patient with pneumothorax who was on the waiting list for lung transplant, but who was successfully operated for a pneumothorax with a fully awake non-intubated thoracic surgery. It has been shown that decreased pre-op FEV1 and DLCO result in higher rates of post-operative pulmonary complications. In our study, we had 2 patients with a pre-op FEV1 of 27%. So on the graph, as shown by Ruo, Zhang, and co-workers, their estimated post-op complication rate would be more than 80%. But there were no complications present at any time during and after non-intubated thoracic surgery. What type of surgery can be done under non-intubated thoracic surgery? Well, virtually all types of thoracic surgery can successfully be performed on the pleura. Also wedging, lobectomies, and even pneumectomies. On the mediastinum, we can perform thymectomies, tracheal resection, and pericardial windows. Pre-medication for non-intubated thoracic surgery is done with light reversible anxiolytic agents, antacids, antiemetics, reassurance, and preoperative sessions of hypnosis. Replacing pharmaceutical premedication, which is a great resource not to underestimate, because 60 to 85% of patients are hypnotizable and 15% can achieve depth of hypnosis for surgery without anesthesia. And there are also various types of hypnomask available, and most of the patients really love it. As usual, standard monitoring has to be applied. But I want to stress the use of BIS, bispectral index, to titrate and avoid oversedation, and in high-risk patients, the use of invasive blood pressure measurements with arterial blood gases, with a central venous line, a urinary catheter in case of epidural anesthesia or surgery of long duration. Now, the mainstay of non-intubated thoracic surgery is regional anesthesia with blocking of the intercostal nerves, of which there are 2 types. The typical intercostal nerve, limited to their own intercostal space, and the atypical intercostal nerve, crisscrossing to other areas. Regional anesthesia for non-intubated thoracic surgery can be performed starting from the vertebra along the rib to the sternum. As you can see on this slide, and we will describe them step by step. Just to mention that the application of each regional anesthesia technique depends on the surgical technique, whether it is a thoracoscopy or a thoracotomy, with its size and location of incision, but this is subject for another detailed presentation. So first, the erector spinae block. Spreading to paravertebral and epidural areas between 3 to 8 levels. Puncture level for thoracic procedures usually is T3 to T4, covering the posterior and lateral thorax. A rare side effect is the Harlequin syndrome, described by Sullivan with ipsilateral interruption of the autonomic pathway and hemifacial erythema. The thoracic epidural block is very well studied with wide clinical experience. However, complications include nerve injuries and epidural hematoma, which are generally below 1%, spinal cord injury with less than 1 in 300,000, and a total spinal anesthesia leading to hypotension and circulatory arrest. This makes a paravertebral block an attractive choice. And compared to the thoracic epidural, there is less hypotension, neither bilateral block nor a bilateral sympathectomy. There is a lower incidence of urinary retention, and it's feasible in sepsis or coagulation disorders, and with neurological disorders, and also with difficult anatomy. In contrast, thoracic epidurals can be difficult to perform, and as mentioned before, there is a risk of epidural hematomas, spinal nerve injury, total spinal anesthesia, and phrenic nerve palsy. But it is a well-known technique with large clinical experience in literature, high success rates, and there is no decrease in tidal volume. This has been proven by Buckingham in the 50s, performing non-intubated thoracic surgery under thoracic epidurals successfully in 677 cases. A comparative study by Zhang and colleagues showed that analgesia was superior in ultrasound-guided paravertebral blocks compared to ultrasound-guided intercostal blocks. The same authors recommend combining paravertebral block with internal multilevel intercostal blocks. Some anesthesiologists add opiates to the local anesthesia solution to obtain an additional analgesic effect, but with a possible risk of respiratory depression. How do intrathecal spinal opiates perform for non-intubated thoracic surgery? Well, there are no studies around for non-intubated thoracic surgery, but Guerth examined analgesic effects of spinal opiates done under general anesthesia for thoracic surgery in about 6,000 patients and concluded that there was effective post-operative pain control after thoracotomy with good safety records and a low incidence of side effects. Itching occurred in 37% and respiratory depression in 3%, but was never life-threatening and always responsive to naloxone. Mahdi Jabari's team showed in a prospective randomized trial of 55 patients undergoing thoracic surgery under general anesthesia that analgesia with intrathecal opiates was equivalent to perioperative thoracic epidural anesthesia. This conclusion is interesting, but as I mentioned before, this study was done under general anesthesia, and therefore, with the current knowledge, the sole use of intraspinal opiates without local anesthesia solution for non-intubated thoracic surgery analgesia is not indicated. However, the question arises whether the combined use of both opiates and local anesthesia could be applied for non-intubated thoracic surgery. And this is quite new in non-intubated thoracic surgery, the use of segmental thoracic spinal anesthesia. With a case report of Awake Thoracic Surgery performed by a team from Bangladesh, Hemel, Seha, and co-workers, with a sensory block at the T1 to T12 level with good outcome. Finally, the ultrasound-guided serratus anterior blame block with two types, the superficial and the deep SAP block, blocking lateral branches of the intercostal nerves from T2 to T9. Another blame block used for non-intubated thoracic surgery are the pectoral nerve blocks, PEC1 and PEC2 type, whereby the pectoral nerve type 1 block should not be used as a sole regional anesthesia technique for awake patients, but combined with a PEC 2 block. Corso and co-workers demonstrated the successful use of PEC 2 and SEP blocks. But the question arises whether there is a regional anesthesia for non-intubated thoracic surgery which can be done on patients with blood clotting disorders and who are on anticoagulant and antiplatelet therapy. The intercostal nerve block provides the answer. A great advantage with the intercostal block is that it can be performed on patients with blood clotting disorders and on those who are on anticoagulant and antiplatelet therapy. In addition, intercostal nerve blocks can be done by surgeons via an intrathoracic approach. However, intercostal blocks carry the risk of a total spinal block and risk for local anesthesia toxicity because of high absorption rates. Another option is intrapleural anesthesia with xylocaine 2% combined with adrenaline or by a patient-controlled analgesia pump. Described by Tang and co-workers, connecting a ropivacaine patient-controlled analgesia pump to the side channel of a 10 French chest tube, as it is shown on the slide. Acupuncture is also a very interesting tool, and during President Nixon's visit to China in 1972, an U.S. delegation observed thyroidectomy and lobectomy surgeries under acupuncture anesthesia. This is a Chinese paper from 1973 on acupuncture anesthesia for a pulmonary resection. Accepting regional anesthesia, another main stem for non-intubated thoracic surgery analgesia are adjuncts used in the opiate-free or better multimodal anesthesia technique, also called OFA, as shown on the slide. What to do when the patient is pain-free but coughs during surgery? First, identify the trigger. Then apply nebulized 2% lidocaine. Further on, escalate to administer endobronchial lidocaine 2% and apply remifentanil. The surgeon can also apply lignocaine on the visceral pleura and on the lung surface. If none of these work out, consider to perform a vagus nerve block, a stellate ganglion block, or a phrenic nerve block. Keeping in mind that vagus and stellate ganglion blocks increase the risk of aspiration and respiratory tract infection. In case of decreasing saturation, airway management should be increased stepwise, starting with nasal oxygen, then high-flow nasal oxygen, a face mask, proceeding to non-invasive ventilation. Application of non-invasive ventilation reduces atelectasis, lowers the rate of respiratory infection, decreases ICU and hospital length of stay, and therefore also morbidity and mortality. In case PaO2 is below 60 mm mercury, PCO2 more than 80 mm mercury, or as some papers quoted, 75 mm mercury, if there is acidosis with a pH of less than 7.1, then consider assist breathing with a Goodell airway or, if necessary, a laryngeal mask airway, and adapt sedation accordingly to achieve more optimal PaO2 and PaCO2 levels. If for any reason this cannot be achieved, the patient should be converted to general anesthesia. Also, in case of surgical difficulties and major issues in hemodynamics and gas exchange, patient discomfort, and failure of regional anesthesia, Conversion to general anesthesia should not be considered as a failure, but a contingency plan. And these are my references which I used for my presentation. Thank you very much for your attention.